I'm sure a lot of you have heard in the news lately about the importance of vitamin D, the new research that's coming out on vitamin D, what's going on. And so tonight, I think we're very fortunate to have our guest speaker, Dr. David Hanley. He's one of the foremost scientists and clinicians that's been working in this, specifically in this field. He's the medical director of the Health Region's Osteoporosis Center. He's also a professor of the Division of Endocrinology and Metabolism at the University of Calgary and Foothills Hospital. He's been around in the Department of Internal Medicine for many years, but I think he's highly regarded by both staff and patients there. He's an internationally respected researcher in bone metabolism and is a leader in vitamin D research and policy development. His research interests have included parathyroid cell regulation, clinical research areas on normal and abnormal calcium and skeletal metabolism. He's also a member of the Osteoporosis Canada's Scientific Advisory Council, which he chaired for 5 years in the 90s, and he recently completed his term as president of the Canadian Society of Endocrinology and Metabolism. With respect to vitamin D, he's chaired the Osteoporosis Canada's Vitamin D Guidelines Committee. He led the writing of Osteoporosis Canada's Vitamin D Guidelines document, and he's on the Endocrine Society's Guidelines Committee for Vitamin D, including acting as a member of the University of Ottawa's expert panel, which won a contract to prepare comprehensive literature review and report for the United States government's Agency for Healthcare Research and Quality. He's quite an esteemed global researcher in the area of bone health and vitamin D. His colleagues actually refer to him as a lovely man, and I understand that he's quite an accomplished musician and a fan of the Kingston Trio. He's also a fellow of the Canadian Academy of Health Sciences, which, for those in the know, is akin to the Canadian Medical Research Hall of Fame. So it's quite a distinction for all he's accomplished in his years, and I'd like you to join me in welcoming Dr. David Hanley.
Well, thank you very much for that introduction. I was starting to wonder who that guy was that he was talking about. But and thank you for the opportunity to speak here tonight. So I am an endocrinologist, and although I'm a member of the Department of Oncology as well, I'm not really an oncologist. I do treat thyroid cancer. I have been involved in early studies of virtually all of the available osteoporosis drugs, and I've received honoraria for speaking and advisory board membership from most of the osteoporosis drug manufacturers. So just to start talking about bone, the world's most incredible feat of engineering is the structure on the right, not on the left. And why is that? It's because it is constantly able to renew itself. We turn over our skeletons at a rate of about 5 to 10% per year. And so bone is a living, growing tissue. It grows in more ways than one. And I may or may not use these terms here, but on the right here you see the, I don't know if I guess the pointer doesn't work, but on the right you see part of this picture, you see what we call cortical bone. That's the outer tough area of bone that, say, in long bones like the forearm or the leg. And then inside, on the left side, is the trabecular bone, which provides different kinds of structural support to the skeleton, and that's where the bone marrow sits, and that's where cancer cells go when they usually when they're going to start invading bone. Just to illustrate the bone turnover. The skeleton can be looked at as being composed of about 30 million little microscopic packets of cells, some of which break down old bone and some of which lay down new bone. So the osteoclasts are the cells that break down bone. That's on the left-hand side. And they're recruited from precursor cells. And then osteoblasts, after the old bone is broken down, the osteoblasts come in and lay down new bone. And that is what you see, it's sort of an orangey material. And if all goes well, we put back all the bone that we took away. If we start turning over our skeletons at a really rapid rate, as you can see, it takes a lot longer to build back the bone than to take it away. And if we don't get the full term there, then we end up losing more bone than we put, or we don't put back quite as much bone as we took away. And that's essentially how osteoporosis develops. We start losing bone in our 30s, actually some parts of the skeleton even earlier, and we slowly lose bone at a rate of about 1% a year. And women lose bone at a more rapid rate for about 5 years around the time of menopause, when they lose estrogen. But osteoporosis is the Rodney Dangerfield of chronic disease. It never gets any respect. People with osteoporosis who have, for example, have a hip fracture and go into hospital, maybe 5 to 10% of them might get the diagnosis of osteoporosis, when in fact it should be about 90 to 95%. And about 5 to 10% get treated with osteoporosis drugs, although having a hip fracture gives you about a 20 to 30% chance of having another fracture within a year. Contrast that with heart disease, where if you go into hospital with a myocardial infarction or a heart attack, you'll come out of hospital with about 2 or 3 drugs in 80 to 85% of the time. Our osteoporosis drugs are actually more effective at preventing fractures than the drugs that people use to prevent heart attacks. So osteoporosis, and the reason I'm dwelling on this is that osteoporosis is the result of one of the major treatments of prostate cancer, is a skeletal disorder with compromised bone strength leading to an increased risk of fracture. And bone strength reflects the integration of bone density, the amount of bone you have, and the bone quality. So you can appreciate that the bone on the left looks better than the bone on the right for several reasons. One, it's thicker, so that's bone density, but it also has more connections, so it's harder to break, and that's the bone quality. And although we used to have a health minister that said that we shouldn't do anything about osteoporosis because it's just a cosmetic problem when people get hunched over as their spine crumbles away. In fact, the bone on the left comes from a 75-year-old and the bone on the right comes from a 45-year-old. It's not a natural product of aging, if any disorder is. Some of you are probably aware of bone density measurements, and when bone density really became available in the 1990s, we lost sight of the fact that fractures really tell you when you've got osteoporosis as well. Bone density tells you, if it's low, tells you that you're at high risk for osteoporosis. But the World Health Organization actually created a bone density definition, and that is if you're quite a bit below the average bone density for a young adult, 2.5 standard deviations is what a T-score is, standard deviations below an average. It's an index of how much, a person's bone density is different from the average for young adults. But in the last 5 to 10 years, we've gone away from just defining osteoporosis by bone density. We now combine bone density with other risk factors to identify people who need treatment. And the people who need treatment are the people who are at high risk of having a fracture. And these are the typical fragility fractures. A fall from a standing height or less causing one of these fractures tells you you're at high risk for osteoporosis or you have it. A hip fracture is almost always an osteoporotic fracture. A spine compression fracture is almost always an osteoporotic fracture. And a fracture of the upper arm after age 50 is almost always an osteoporotic fracture. A wrist fracture is a warning sign, and it could well mean that you have osteoporosis. So in the last 10 years, we've come back to the idea that fractures trump bone density. So if somebody's had one of these fractures, I may not care what their bone density is. I may want to treat them. So osteoporosis does occur in men. Even this very masculine fellow right here, some of you might remember Austin Powers. But here's a famous but typical osteoporosis victim, and that's the late Pope. He was an athlete in his younger years, a very skilled skier, as I understand it. He had, you can see he's got a markedly curved spine. He'd lost probably 5 or 6 inches of height. He had at least one hip fracture. And if he was, this is an older slide, it's probably more like 85% of Canadian men with a similar history. If he was like them, he wouldn't be getting treated. Which is a shame because our treatments can reduce the risk of another fracture on an average by about 50%. So we've developed some clinical practice guidelines for diagnosis and management of osteoporosis, and I won't bore you with too much here. But except for who should get bone density, we feel that all women and men over the age of 65 should get a bone density as a screening procedure. The United States would say men over age 70, because men are less likely to have fractures. And then there are a number of other risk factors that, if they're present, might make you get the bone density done earlier. I won't go into the detail. But then we put bone density into a composite with risk factors. And the basic risk factor is age. The older we are, the higher risk we are for fracture. And so if you have a very low bone density and you're in the 60 to 70 range, that's probably a time to be treated. We regard high risk as a firm indication for treatment, and moderate risk, certain setting is some people would prefer to be treated, some would prefer to take a conservative approach. And so this is our integrated approach. If we start with bone density and assessment of fracture risk, combining risk factors. If the person is at low risk, they're unlikely to benefit from drug therapy. If they're at high risk, there's pretty good evidence that they will benefit from drug therapy, in addition to the lifestyle modifications that I would recommend. And then if they're at moderate risk, then it becomes a decision. And one of the things we often do is look at the spine by x-ray. And if the spine has a compression fracture in it, then that person automatically bumps into a high risk category. So there are a whole bunch of things that might make us take a moderate risk person and give them therapy. And I've put in red here and emphasized men on androgen deprivation therapy for prostate cancer. So if your bone density and age puts you in the moderate risk category and you're getting that, you should probably strongly consider an osteoporosis therapy to reduce your risk of fracture. So fractures for women, if you're at age 60, up to 56% of women at age 60 have a risk of having a fracture in the remaining lifetime. And the risk is close to 30% for men. And these are the typical fractures of osteoporosis. And you'll notice that women get wrist fractures, whereas men don't seem to. And the reason for that is that women go through menopause, they lose estrogen dramatically, and that really weakens the wrist. And so falling will often precipitate a wrist fracture. But it's the hip fracture and the spine fractures that are the real worry. And the hip fracture, of course, is a major catastrophe. It's associated with more disability than a stroke. It's one of the major causes for people losing their ability to live independently. And about 30 to 40% of people who have a hip fracture will never regain the same level of mobility and independence that they had before. Osteoporosis in men is just the reverse of heart disease in women. When women get heart disease, they get it at a later age, but they're more likely to die of it. And in men, they get hip fractures and spine fractures at a later age, and they are more likely to die from them. So our non-pharma drug therapy for osteoporosis, everybody should get about 1,200 milligrams of calcium a day. Now, a diet without dairy products a typical Canadian diet without dairy products gives you about 400 milligrams of calcium. A cup of milk, a cup of yogurt, or a cup of one of the calcium-fortified beverages, calcium-fortified orange juice gives you 300 milligrams. So if you have 3 dairy servings a day, you don't need to take calcium supplements. We recommend 400 to 1,000 units of vitamin D daily for men and women aged 19 to 50, and anywhere between 800 and 2,000 units for people over the age of 50. And a generally healthy lifestyle, a good diet, exercise, and stop smoking. And don't drink any more alcohol than I do. Actually, we do look on people who have more than 3 alcoholic drinks per day as being having a risk factor for osteoporosis. I won't spend a lot of time on vitamin D, but I think it's worth emphasizing that we get our vitamin D either from ultraviolet exposure of our skin, and that really means bathing suit exposure, or from our diet. But the average Canadian diet has about 200 units of vitamin D in it, so we won't get enough vitamin D from our diet as a rule. A liter of milk has 400 units in it. So vitamin D is synthesized in the skin, and the skin is a method of making sure you don't make too much vitamin D. Whereas if you're getting your vitamin D from diet, you can get too much, but you're safe without any medical supervision in going up to a dose as high as 4,000 units a day. Vitamin D is carried in the blood to the liver, where it is converted to something called 25-hydroxyvitamin D, and that's what we measure when we're checking for vitamin D deficiency. And then vitamin D is converted in the kidney to the vitamin D hormone, which is calcitriol or 1,25-dihydroxyvitamin D. And that is the biologically active form of vitamin D. And that, from the kidney, that circulates and controls our ability to absorb calcium and phosphate. But on the right-hand side is something that has interested a lot of people about vitamin D more recently. And the ability to make calcitriol, or the vitamin D hormone, is present in many tissues that we didn't realize before. And one of those tissues is prostate. And we think, and there's increasing evidence that prostate cancer can be regulated, and the growth of prostate cancer can be regulated by vitamin D. There's controversy as to whether prostate cancer has lost the ability to make vitamin D, the vitamin D hormone. And some of my colleagues are doing studies looking at analogs of that vitamin D hormone in the treatment of prostate cancer. And some of the early studies of prostate cancer in animal models and in tissue culture models are very promising. At this stage, though, our main message would be for people who have prostate cancer to make sure they have enough vitamin D. And this is just an expansion of the last slide, just emphasizing that part of the functions of the vitamin D hormone is regulation of cell growth, and that's important for cancer. So population studies have shown that low vitamin D levels are associated with increased risk of prostate cancer and breast cancer and colon cancer and a number of other cancers. And there may be a prevention benefit of higher vitamin D levels. Some studies, though, have also suggested if your blood vitamin D levels are very high, you may be at risk for some other cancers. So that story is not quite answered in full yet. But I think it's very clear that people who are really deficient in vitamin D are at higher risk for cancer. And so I think it is important to do your best to avoid vitamin D deficiency. But in the androgen deprivation therapy that a lot of people with prostate cancer get, so that to shut off their testicular production of testosterone, people are either given blockers of testosterone synthesis or they're given injections to stop the pituitary from stimulating the testes to make testosterone. Calcium and vitamin D alone will not prevent bone density loss during androgen therapy, androgen deprivation therapy. And this is a review of 12 different clinical trials. And the black bars that you see below the line mean that in those studies, that people lost up to 4 or 5% of bone mass in those studies. Now, there's a large study going on in the recruiting in the United States looking at 2,000 units of vitamin D plus fish oil and other components to see if they will prevent cancer. It's going to be a large 5-year study. Many of us in the vitamin D field actually think that they're using too low a dose of vitamin D. But this is a huge study that is going on right now. And we'll hear the answers probably in 5 years or so. So osteoporosis drug therapy is important for people to know about if they are on androgen deprivation therapy. And in the interest of time, I don't think I'll go through a lot of details about it, but basically most of our osteoporosis therapies are directed at preventing bone loss. And that is effective in reducing the risk of breaking bones by about 50%. We currently have one drug that is directed at the bone forming cells, but that's something that we probably would be a little less interested in using. And actually, I think in the package insert it says that that drug is not supposed to be used in patients who have a cancer history, and that's parathyroid hormone. So the main drugs that we use are called bisphosphonates, and alendronate is Fosamax, risedronate is Actonel, and in prostate cancer, zoledronic acid is the one that's currently being promoted a lot. That's an intravenous treatment, and for osteoporosis, we give 1 injection a year. In prostate cancer, or in breast cancer, and in the ones where we're trying to prevent bone cancer from spreading to bone, we give it once a month. And since our guidelines came out, another drug called denosumab has come on the market, and it also is given by injection, just an under the skin injection, and that's given once every 6 months for osteoporosis. So these are this slide just illustrates on the left you have the bone forming cells, osteoblasts. On the right you have osteoclasts. And the bone remodeling sequence gets started by a variety of stimuli, and the osteoblast releases something called rank ligand. And rank ligand, attaches to osteoclast precursors and stimulates them to turn into osteoclasts and start working on and in breaking down bone. Denosumab is an antibody against rank ligand, and it binds to rank ligand and prevents the activation of bone breakdown. Estrogen therapy, which is an effective osteoporosis therapy, works on the osteoblast to just slow down the whole process of bone turnover. And there are drugs called selective estrogen receptor modulators that act like estrogen on bone but not on breast. And these drugs are being used for some people with androgen deprivation therapy in prostate cancer because they mimic the effects of estrogen in bone but don't cause breast development or other things that people don't like. And on the right, you see bisphosphonates. Those are the drugs like zoledronic acid and alendronate. They bind to bone mineral. The osteoclast takes them up, and then they poison the osteoclast so it doesn't break down bone. So age is a big risk factor for osteoporosis and fracture, and prostate cancer tends to occur more in older people. So anybody with prostate cancer probably should be thinking about osteoporosis. Anyone who's in the typical age of prostate cancer should be thinking about osteoporosis. But androgen deprivation therapy is, in the second bullet there, is a very important stimulus to bone loss. And that bone loss can result in fractures. So, and we do that by things like the injections that you get called Eligard, that's gonadotropin-releasing hormone therapy, and that shuts off the pituitary stimulus to testosterone synthesis. Or you can take drugs that block androgen synthesis. Now, the other thing that happens with prostate cancer is that it can spread to bone. And prostate cancer is very interesting in that regard because it's one of very few cancers that when it spreads to bone, it actually stimulates bone to grow. So if we could capture what prostate cancer is making, we might have a new osteoporosis treatment. But when it spreads to bone, it also expands the bone. And so people get pain from the invasion of bone, even though the bone is maybe getting stronger. The bone expands, and sometimes if it's in the spine, it can actually start compressing the spine, spinal cord, or nerves coming off the spinal cord. And even though it's building bone, this bone may not be, although it's more dense, it may not be as strong, and so it may fracture. So we look at what we call skeletal-related events, and that would include fractures, metastatic disease to bone, bone pain, a need for radiation therapy of bone. And then we also look at androgen deprivation therapy. So looking at androgen deprivation therapy, the more of the GnRH therapy you get, and over the longer time, the more bone you lose. And this is, this one looks at, this is a paper that came out in 2005 showing that the longer you're on this therapy, the higher your fracture risk. So that people who have their testes removed or have had more than 9 doses of Eligard have, if this goes on for 8 or 9 years, less than 50% of them will have gone through that time without having a fracture. On the other hand, the upper panel would be people who did not get androgen deprivation therapy, the upper line, and you can see how only about 30% of those people have had a fracture in 10 years. So this therapy does increase your risk of fracture. So osteoporosis, with androgen deprivation therapy, your risk is about doubled. Your risk of a fracture is increased by about 1/3. And fractures leading to hospitalization, the risk there is about doubled by taking androgen deprivation therapy. And not only that, the fractures that are linked to androgen deprivation therapy are also associated with an increased risk of dying. Now, a systematic review is something that people in the medical field like, and a review of a large number of studies. And that just confirms what I've just been saying, that androgen deprivation therapy increases your relative risk of osteoporosis. And this looks at bone density in the years of androgen deprivation therapy from all of these studies. And you could see as the longer people are on androgen deprivation therapy, the lower their bone density is. Now, something that a lot of people never really realized is that, we think that testosterone is good for bone, and men have better bones than women, stronger bones. But actually, testosterone doesn't do very much for bone, except it's converted to estrogen. And so estrogen is an extremely important hormone for bone, both in men and women. And in rare male individuals who have either the inability to make estrogen or they lack an estrogen receptor, they have terrible osteoporosis. It's estrogen also that stops you from growing when you go through puberty. And because boys don't make as much estrogen as girls, they go through puberty a little longer than girls do, and they end up being a bit taller. But eventually, it's estrogen that closes the growth plate and prevents further growth. Estrogen would correct most of the problem that people have with androgen deprivation therapy, but most men who've been treated with estrogen for prostate cancer have not really enjoyed it. So it really has fallen by the wayside. But selective estrogen receptor modulators, like toramifene or raloxifene, have been used in some trials with androgen deprivation therapy to have a beneficial effect on bone. And in the setting of low estrogen and low testosterone, these drugs are moderately effective. So the metastatic bone disease of prostate cancer usually starts in the bone marrow because there's lots of blood in the bone. And the tumor cells establish a cooperative relationship with the bone cells. So you don't need to copy all of these factors down that the prostate cancer cells make, but they release a whole bunch of growth factors and things that stimulate bone cells to make more bone, actually, as you can see in the lower right-hand panel. Or they cause, also, they may stimulate osteoclasts to release growth factors from bone. So in this slide, we actually see the prostate cancer cells stimulating osteoclasts on the right, stimulating osteoblasts, and the osteoblasts in turn stimulate other bone marrow cells, which then release growth factors which cause the prostate cancer to grow even more, and it sets up a vicious circle. And so, and with the osteoclast working, it prepares the bone to accept more cancer cells. So drugs that inhibit osteoclast recruitment or action have been shown to reduce the burden of metastatic disease and skeletal-related events. So bisphosphonates have been used. One of the oncologists here in Calgary, Sandy Patterson, who's mainly worked with breast cancer, pioneered this field. And he worked with one of the early bisphosphonates called clodronate, and later with pamidronate. But more recently, we've gone to zoledronic acid, which is more potent. But all of them reduce the load of bone cancer, or cancer going to bone, and other skeletal-related events. That's such as pain requiring radiotherapy. The doses that we use are much higher than what we use for osteoporosis therapy. For example, zoledronic acid, we give 5 milligrams once yearly for osteoporosis. For prostate cancer and breast cancer, in the centers that are doing this, and not all centers go along with this, they're giving 4 milligrams intravenously every 3 to 4 weeks. And denosumab is marketed as Xgeva for prostate cancer and breast cancer. And that, instead of giving 60 milligrams once every 6 months for osteoporosis, they give 120 milligrams every month. And that blocks osteoclast activity. And it's been shown that zoledronic acid and denosumab are effective in several cancers in reducing the number of skeletal-related events. And that's what this is. And prostate cancer is the second one from the top. And it's and denosumab, compared to in a placebo-controlled trial, reduced the incidence of new vertebral fractures in men with prostate cancer. Now these, let's see, I always forget what each, hormone resistance prostate cancer, again, these would not respond to androgen deprivation therapy, but they do get metastases and skeletal complications. So almost all patients with cancer, prostate cancer, do get some effect on bone. But looking at skeletal-related events, again, with zoledronic acid, we reduce them. And so these are some of the events we look at. Radiation therapy needed for bone, fractures, spinal cord compression, the need for other chemotherapy, surgery on bone, or a high blood calcium. And all of these are more common in people who did not get zoledronic acid in that trial. And in the clinical trials with denosumab, there are 3 major clinical trials that have looked at, and prostate cancer is just one of the studies. And in prostate cancer, it actually looked a little better than zoledronic acid. Risks. Well, with bisphosphonates, there's a risk of kidney damage if the intravenous drug is given too quickly. About 10 to 20% of people who get these drugs intravenously have a flu-like reaction to the first injection. It responds to Tylenol, but it can make some people pretty miserable. But it's only with the first injection, and it usually doesn't happen after that. It's not an allergic reaction. Now, if you're vitamin D deficient, both of these drugs will cause your blood calcium to go very low. If you're not vitamin D deficient and you have a reasonable calcium intake, your blood calcium may drop to the lower end of the normal range or slightly low, but it won't be too bad. But really low calcium can be life-threatening. And so that's another reason to make sure you've got vitamin D. And the one thing that's been worrying a lot of people about these 2 drugs and being used like this is something called osteonecrosis of the jaw. And that's where you have exposed bone open to the mouth in the upper or lower jaw, and it persists for more than 8 weeks. Now, radiation therapy can do this to you as well. But in prostate cancer, being treated with these drugs in high doses, the risk is around 5%. And when you get it, it's no fun. This is an example of it. Now, this is a severe example of it. It's much more common in people who have pretty poor dentition to begin with, but it can occur in people who have been looking after the teeth very well. Now, this is a severe case. Most of the cases that we see respond and heal over with antimicrobial mouthwashes. But when it turns into something like this, that's extremely painful, and it may even require surgery. And the risk of that, you can see on the left panel, the percentage of patients with this in these clinical trials is around 1 to 2%. And denosumab actually was slightly worse than zoledronic acid. However, the difference is that denosumab wears off after when you stop it. And so the people with this disorder who take denosumab get better. But in 95% of the patients, all that was required to treat it was just the antimicrobial mouthwash. But the resolution rate occurred quickly in most of them, but seemed to occur more quickly in the denosumab group. There are a few other therapies that are on the horizon. Radium-223 actually is an element that seeks out bone, and it is. I think, if I remember correctly, it's an alpha emitter, which has a pretty short beta emitter. I think it is a short radius of effect, but in the preliminary results, it did improve survival in patients with bone metastases. And there are other isotopes that are bone-seeking isotopes that are being looked at. And there are some new chemotherapies that are being looked at for bone. So I just leave you with the fact that I think bones are important, as these boneless chickens will attest. And we want to have strong bones. Thank you. Bye. And I hope I didn't spend too much time there. I'm happy to answer questions. Yeah.
You've mentioned several drugs that you say are being prescribed. Are they in fact funded by Alberta Healthcare Services?
Well, they're not for osteoporosis. Well, they are for osteoporosis under special circumstances by Alberta Blue Cross for seniors. For zoledronic acid is available through the day medicine centers at the hospitals, and it is indicated for metastatic disease or high blood calcium. So theoretically, that would come out of a hospital budget. I'm not involved in the studies here in Calgary at Tom Baker Cancer Center of these drugs, so I know that for some of the cancers that it has been used, the local hematologists or oncologists are not enthusiastic about using them in, say, multiple myeloma, for example. The breast cancer group is one that pioneered the use of bisphosphonates. So they are either doing studies with these drugs or they are prescribing them. And I believe that the prostate cancer group has either been involved in the studies or are using them in some patients. But they may be being more selective in choosing people to treat with them and not suggesting that everybody should.
Just a further question.
Oh, yeah, thank you. Yeah.
For those of us on ADT, there's been some suggestion, certainly coming from the United States, that some of the side effects of ADT can be mediated if you use estradiol patches.
Yes.
And you were suggesting that some people don't enjoy it or what have you. So
well, yeah.
What's the issue there?
Yeah, the issue is feminizing effects, breast development. But in fact, when you take away testosterone, just a low testosterone level is often associated with what we call gynecomastia, some breast development. So it's not really that big of a problem. Absolutely, estrogen actually is a great drug for osteoporosis, and it will.
So for those of us that have been on Lupron and Eligard for a long time, we've already been conditioned to whatever the circumstances are in terms of breast development and hip development and all that kind of thing. And we have hot flashes. And we are losing bone density. Are you suggesting that we should consider taking the estrogen patches or using
Well, yeah, you have to talk that over with your oncologist, but it certainly may be effective, and it should not stimulate prostate cancer to grow. So
it's good for the bones.
And it should be good for bones. It's actually great for bones. For women as well, but the problem, of course, is that it is a lot of excess baggage that a lot of women don't want to put up with. But in this setting, actually, it was one of the, in the earlier days, people treated men with prostate cancer with high-dose estrogen therapy to shut off the pituitary stimulation of testosterone production. And that, of course, would protect their bones. The other alternative, though, is to go to just a standard osteoporosis therapy, not the prostate cancer dose of zoledronic acid, for example, but just for example, the once yearly zoledronic acid, which is very effective in preventing bone loss and reducing fracture risk.
Does it reduce, we have many warriors that have rising PSA.
We can't hear this discussion in
Oh,
the
I'm
back.
sorry.
Nobody hears it
Okay.
from about that row back.
Okay.
I'm sorry.
We have many men who have rising PSA after primary treatment. And my question would be, should they also consider the estrogen patch? So therefore they've had radiation therapy. And now they have rising PSA.
That's a tough question for me to answer because if they're on androgen deprivation therapy, it's certainly something to consider. Or one of the other osteoporosis therapies. Either one would. I don't think it would augment the prostate cancer benefit of androgen deprivation. It would provide some bone benefit, bone strengthening benefit, but I don't think it would have any effect on the risk of prostate cancer spreading the bone.
Can you comment on omega-3 and prostate cancer?
I'm afraid I can't. I'm not, in general terms, I'm not aware of its benefit on bone. That was mainly my focus, and so I can't. I'm not an oncologist, so I can't really. I'm not up on the literature on omega-3 and.
Yeah. Can exercise help strengthen your bones, and if so, what kind of exercise?
Yeah, exercise is good for bones, and when we look at bone density, we don't see much of a benefit. But but if you don't exercise, you lose bone. Many of us believe that although bone density is a very crude tool, and it doesn't tell us anything about what's going on at the microstructure level of bone. And I would suspect that exercise actually does strengthen bone. There haven't been large enough studies of exercise to talk about a major effect on fracture prevention, but I never discourage exercise for bone. And the kind of exercise you need to preserve bone is weight bearing. Walking is just fine. And weight bearing for the upper spine can probably be augmented a little bit by doing repetitions of light weights with your arms. But walking is an excellent exercise. And studies of animals have shown that you don't need to be exercising at the level that used to be suggested for cardiovascular disease. It doesn't take very much weight-bearing exercise to maintain the skeleton.
How about bicycle?
Well, actually, any muscle pulling, any exercise that gets muscle pulling on bones will be beneficial. Swimming actually will be beneficial too, but because cycling and swimming are not as much weight-bearing, they won't have the same effect as walking or other exercises that involve actually putting weight down through the spine and on the hip. It's the spine and the hip are the areas that are most affected when you stop exercising. Yes.
Are there any detrimental effects to the higher dosing of vitamin D? And is there seasonal dosing to it, more in the winter than, say, the summer?
So Health Canada has taken a very conservative approach to vitamin D. But the Canada Food Guide does recommend, which is sort of an arm of Health Canada, does recommend that Canadians take a vitamin D supplement at least in winter. If you went outside naked in winter from about October on through well into March, you wouldn't make any vitamin D here in Calgary. And the farther south we go, the longer the vitamin D generation season is. So in my view, all Canadians do need to take vitamin D supplementation at least in winter. I happen to believe that our vitamin D levels need to be higher. And so I'm taking 3,000 units a day, for example. 3,000. Health Canada's ruling on this is that for bone, most of us will be served by taking no more than 400 units of vitamin D up to age 70, because you get about 200 in your diet, so you get a total of 600. And about 800 units a day after age 70. But they've set what they call a tolerable upper intake level. That is an intake level that has not been associated with any harm at 4,000 units. So you could take up to 4,000 units a day without any medical supervision. Whether that provides you additional bone benefit remains controversial. I happen to think it does. Certainly, what we recommended in Osteoporosis Canada for people over age 50 was 800 to 2,000 units a day in that range. And that should bring your vitamin D levels up to a level that has been associated with some fracture prevention benefit.
Are you familiar with the Pure North Synergy?
Yes, I am. Actually, they're funding one of our studies on vitamin D.
Because they recommend 5,000.
Yeah, they do. And they monitor it. Yeah, so you're above they're above 4,000. And so they monitor blood levels and monitor the safety of it. And as far as I can tell, they're doing fine with that.
That's sufficient monitoring.
Yeah, they are. Now, what they're doing is certainly not endorsed by everyone. Some of my colleagues in the United States would be horrified by them.
What are the detrimental effects of too much vitamin D?
Well, if you get way too much, you absorb too much calcium and phosphate and you start to make kidney stones. Or your blood calcium goes too high, and that can start to interfere with normal thinking and other things. The studies that have shown that vitamin D deficiency is associated with an increased risk of cancer are all pretty what we call association studies. They haven't really been demonstrated in what some of the evidence-based medicine people prefer, which would be big clinical trials, randomized clinical trials. Similarly, there are a few association studies that have actually shown that when your blood level of vitamin D gets above about 125, which would happen if you get over about 4,000 units a day, that actually there starts to be an increased risk of some cancers. Pancreatic cancer is one that's been linked to it. Prostate cancer is one that has been linked to that. Although most of the studies that look at prostate cancer really show that when you're deficient in vitamin D, you're at much higher risk. There's enough little worry in there that when the Institute of Medicine panel made recommendations to Health Canada and to the American equivalent, they said we shouldn't go above 4,000 units a day. I think I'm actually involved in a study that's going to look at doses up to 10,000 units a day with careful monitoring.
So what's your view on taking vitamin D in liquid form versus pills? My respirologist told me I should be taking it in liquid form.
I don't have a strong feeling on that one way or another. The liquid form is made by a few companies in Canada that have pretty strict quality assurance. And so there may be some tablet forms that are not so good, but I think the tablets that people use, like that are sold, say, at Costco and Safeway and so forth, Jameson and other, are pretty good. And but I do, I have a few patients in my practice who seem to be taking large doses and not getting anywhere with it. And one of my friends in New York has published a small study suggesting that vitamin D is best taken with a fatty meal. Vitamin D is stored in your muscles and body fat. You don't need to take divided doses throughout the day. You can actually take one big dose once a week if you want. But if you get out to once every 3 or 4 months with a huge dose, there's a little evidence that it may not be of benefit at all.
Just one further question. I never had my vitamin D measured until about a year ago, but my oncologist kind of scoffed at the vitamin D measurements, said they were not reliable at all. You mentioned if you're over 125, you're in danger. My last test happened to be 127, so now I'm worried.
Yeah, I wouldn't be worried about that. And the Institute of Medicine characters
Do you
are
think
that.
that the tests are reliable?
The test has some vagaries, but basically it's pretty good. It is reliable. For most people, though, they don't need the test. Just take vitamin D. For most people, taking the kind of doses that I recommended, the 800 to 2,000 units definitely is safe. And for most people, that will bring their vitamin D up to a level that will protect bone.
Who are the other people?
The other people, you mean the people that don't like it?
No, you said for most people taking
Oh,
vitamin D.
oh, there-
you
yeah.
don't need it in bone density test. Who are the people that should have?
Well, anybody who has a condition that vitamin D deficiency might be common in, someone like, say, with celiac disease, who has malabsorption problems, those are people who need their vitamin D intake monitored. People who are markedly overweight seem to, we don't know exactly why, but they do have very low levels of vitamin D. People with inflammatory bowel disease, anybody with osteoporosis, those people have a condition that'll be made worse if their vitamin D isn't adequate. So they should be monitored. And I do see some people there, and I have no idea why, but I'm treating some of those people with 50 or 100,000 units a week.
Cholesterol, what's that good for? Cancer?
The treatment for
Cholesterol, what is it? Cholesterol. TES?
Cholesterol.
Yeah.
What is it?
sorry, I'm sorry, I'm partly deaf, so
What is it good for? Is it that makes the cancer grow or decreases the cancer?
Sorry, testosterone.
testosterone. Okay. Yeah. Well, for the hormone-dependent forms of prostate cancer, yes, it will stimulate the prostate cancer cells to grow, and so that's why we use the androgen deprivation therapy.
How much sun are you, vitamin D you get from the sun? You live in Hawaii for 4 hours a day for what?
Okay, well, that's an interesting question. Your skin actually has a built-in mechanism of shutting off vitamin D synthesis, but about a 10 to 15 minute bathing suit kind of exposure at the peak ultraviolet time of the day will make somewhere between 10 and 20,000 units of vitamin D. That's part of the reason why I think that probably we could handle bigger doses than 4,000 units, but that remains to be proven. Yes?
What's the difference between vitamin D and vitamin D3?
Vitamin D3 is the vitamin D that your body makes due to sunlight exposure. It is the natural form of vitamin D for us animals. Vitamin D2 is made by ultraviolet exposure of mushrooms and fungi, and it was the vitamin D that was used in supplements in the United States. The rest of the world uses vitamin D3, and the United States is slowly moving over. And vitamin D1 was a laboratory error.
When you buy a bottle of vitamin D at Costco,
That's vitamin D3. In Canada, that's vitamin D.
it's labeled both ways. You'll see a bottle that says vitamin D, and then you'll see a bottle that says
Vitamin D3, and that's all vitamin D3. Yeah. The vitamin D2 is available in Canada, but in pediatric liquid form, it's available as Drisdol, I think it's called. And then the 50,000 unit tablets of vitamin D are vitamin D2. Vitamin D2 is not quite as, there's controversy with this, but it's not quite as potent as vitamin D3. But it goes through the same pathways, and if it's taken regularly, it will do the same thing as vitamin D3.
Thank you.